Hello, my name is Cassandra Cotton, and for my outbreak case study presentation, we'll be covering polio. The specific outbreak of poliomyelitis, or polio, I will be discussing today began in the U.S. in 1949 and peaked in 1952. I chose this time frame because while there were certainly cases of polio in the U.S. before 1949, beginning that year, polio had seen a new record-breaking number of cases, which would ultimately be topped on the charts by 1952, the year we will be ending on. Much emphasis of my discussion will focus more closely around 1952 since that was the most brutal year in U.S. history for polio, and there are some interesting sources I was able to discover surrounding that year. The outbreak spread throughout the entire U.S., with concentrated pockets ebbing and flowing throughout the epidemic. Polio is a highly infectious disease that invades the nervous system of those who contract it. Polio is a viral disease that is spread from person to person, most commonly through contact of fecal matter and contaminated food or water sources, but is sometimes spread through droplets spread from the pharynx of an infected individual. While around 70% of infected individuals experience no symptoms, and many experience symptoms that mimic the flu, polio can also be potentially life-threatening, entering the spinal cord and paralyzing the infected individual. Of those paralyzed, around 5 to 10% die when their muscles immobilize or they can no longer breathe. Unfortunately, there is no cure for polio, only preventative measures that can be taken, such as routine vaccination. Polio is most likely to affect children under the age of 5, but any unvaccinated individual could contract polio. Unfortunately, during the polio epidemic between 1949 and 1952, no such vaccination existed to prevent children from contracting the disease. It was reported that the U.S. experienced a peak in the polio epidemic during the fall and summer months, and that individuals were most infectious in the days right before the onset of symptoms. The incubation period for non-paralytic polio is 3 to 6 days, while the onset of paralysis in paralytic polio is typically 7 to 21 days, with the risk of severity of the disease and death after infection increasing with age. Ironically, increased sanitation efforts in the 20th century led to decreased exposure to polio during infancy, resulting in children being older at the age of primary infection, causing death rates and epidemics to skyrocket until the creation of the oral vaccine in 1955. In earlier U.S. epidemics, average age of contraction occurred most commonly between ages 1 to 5, while in the 1950s the average age of contraction was 6 years old, and a large proportion occurring in teens and adults. Because polio has a long incubation period and many people are asymptomatic, it can be difficult to track it as it spreads throughout the population. Polio surveillance therefore consists of identifying patients that have symptoms which align with polio or through testing of stool samples. From sources we will soon discuss regarding distribution, cases reported, and death rates for 1949 and 1952, surveillance on polio was being gathered from the National Office of Vital Statistics and the local, state, and federal public health departments, who would have gained case information from healthcare providers, hospitals, and labs testing for and recording any occurrences of polio, and created detailed reports outlining their findings. The Global Polio Eradication Initiative sheds light on the steps taken to identify and investigate the spread of polio, suggesting that surveillance systems for polio must be tight, enabling public health officials to diagnose even one case of acute flaccid paralysis, or AFP, in every 100,000 children, even if polio is absent from the area. First, identifying and reporting all patients under the age of 15 who are experiencing acute flaccid paralysis, in addition to public health officials doing routine checks for individuals whose symptoms may have been misdiagnosed or missed. Then, all children displaying symptoms of AFP submit fecal samples to be tested for wild polio within 48 hours of onset of symptoms, and the specimens arriving to the lab within 72 hours of stool collection. If poliovirus is detected, it is then isolated and identified, and further testing is carried out to determine the origin of the outbreak. Genetic makeup of polio strains help public officials track and identify clusters of polio defined in geographical areas. Additionally, public health officials carry out environmental surveillance through testing samples of sewage or water sources for poliovirus, especially in the absence of paralytic cases. Cases of polio are split into two differing definitions because of how they present. paralytic, and non-paralytic. For paralytic polio, a case is defined as a person displaying acute onset of flaccid paralysis with decreased or absent tendon reflexes in the affected limbs in the absence of a more likely alternative diagnosis, plus a confirmed positive test for polio. A case for non-paralytic polio only needs to have a confirmed positive lab test for polio. Index cases for the polio epidemic of 1949 to 1952 are nearly impossible to identify because it was prevalent during many years prior, and cases which are asymptomatic are difficult to trace. Additionally, there was really no end to the epidemic until well after 1952, as demonstrated by this graph displaying polio death and case rates in the United States from 1910 to 1970. Cases wouldn't start to really plummet until after the 1960s, coinciding with the creation of the polio vaccine. Let's start by looking at the prevalence of polio in 1949, when this specific epidemic first began in the United States. In a report covering polio in 1949, it is reported that of 50 states, 48 were reporting their data back to the government for surveillance purposes. Per 100,000 people, there were approximately 28.3 cases with a death rate of 1.6, with overall figures coming in much higher than 1948. The highest morbidity rates occurred in Maine, Massachusetts, Connecticut, Michigan, Arkansas, and Oklahoma. Primary areas experiencing outbreaks included the Midwest and Rocky Mountain regions, as demonstrated by the map provided, and the report states that of the 24 counties with relatively high rates, none had been entirely free of the disease for 5 consecutive years. And while the incidence of polio was relatively high in 1949 when compared with previous years, the death rate was relatively low. But by 1952, the epidemic had gotten much worse. In a report covering the poliomyelitis distribution in the U.S. for 1952, it states that the number of cases of poliomyelitis reached 57,879, a 38% increase from the year prior, and the highest peak in U.S. history unbeknownst at the time. States listed as having the highest incident rates were Nebraska, South Dakota, Minnesota, Iowa, and Kansas. Additionally, around 37% of reported cases were classified as paralytic, with around 41% designated as unspecified. Final totals for paralytic polio cases amounted to more than 20,000 cases by the end of 1952. The distribution map on the slide was also pulled from the Dower report and very clearly demonstrates how hard the middle of the country was hit during the peak year of the epidemic. In another report by the National Office of Vital Statistics, it states that Iowa had experienced its own epidemic of polio in 1952 within the larger outbreak, with the largest concentration of cases in the western U.S. and Sioux City at the center of the outbreak. Additionally, the report states that there was low incidence of cases reported along the Atlantic coast and in the Rockies, aside from New Mexico, as also demonstrated by the distribution map. This graph was pulled from the World Health Organization's site, allows us to see the polio epidemic between 1949 to 1952, as well as the years around it to give some context to what we are seeing. This particular epidemic begins and ends with high case rates, with 28.07 in 100,000 people contracting polio in 1949 and a death rate of 1.82. By 1952, the case rate had risen to 35.61 and the death rate was at 1.94. To further demonstrate how hard-hitting this particular polio epidemic was, I wanted to use the example of Iowa's experience with polio in 1952. While Iowa had averaged around 1,300 cases yearly from 1948 to 1950, they experienced more than 3,500 cases in 1952 alone, with around 25% of them occurring in Sioux City, which led to public health inspectors in the area being very strict about every case being reported and investigated back to the government. Additionally, quarantine and sanitary measures were put in place, and even parents were barred from seeing their children as they were whisked to isolation wards for treatment. The epidemic was marred with images of young children in iron lungs after paralytic polio left them unable to breathe without assistance, and Iowa was no exception. Pictured here, you can see parents thought of clever ways to see their children during this difficult period of separation, peering into windows as they balance on a ladder, as well as a patient inside of an iron lung. Also during this time, around 16,500 children in Sioux City were enrolled in a nationwide gamma globulin vaccine trial. While I was unable to find any statistics on the breakdown of different races affected by the polio epidemic, I did find an interesting article about the intersection of race and polio. Before the epidemic period, I chose to discuss polio was widely thought to be a white disease, contributing to medical racism and neglect, with Black patients unable to get access to adequate medical care during polio outbreaks, particularly for those needing iron lungs due to acute flaccid paralysis. Civil rights activists challenged this damaging belief by advocating for equal access to health care regardless of race. Additionally, the article speaks to the likely underreporting of polio cases among Black patients because there was no recognition or treatment for the victims. After many hard-fought battles, some establishments made efforts at promoting integration and training programs in healthcare facilities. Eventually, Black children were included in vaccination trials and national vaccination programs, but not without a lot of suffering and pleading leading up to that point. The same is probably said for other minority groups that would have been barred from seeking treatment at whites-only facilities. As mentioned previously in this presentation, other health disparities associated with poliovirus include age of first infection, with young children being most susceptible and children presenting with worse symptoms at a later age of onset. Common prevention methods at the time included avoiding social gatherings, including large events being postponed or canceled, and shutdowns of common areas such as public pools, movie theaters, and at times schools. Parents were constantly on the lookout for any slight symptom of polio and were diligent with their hygiene and sanitation measures. Many of the preventative measures taken during polio are similar to the measures recommended during the COVID-19 pandemic. Unfortunately, until the invention of the polio vaccination, there was little to be done about the spread of polio. The hard-hitting impact of the polio epidemic in the United States between 1949 and 1952 both began and finished with record-breaking polio cases. This particular stretch of years caused a lot of fear in the public as they watched children lose their ability to walk and breathe to paralytic polio. And I think that sparked a more aggressive push than ever before to develop a polio vaccine and put an end to the epidemic for good. This would prove to be fruitful as finally in 1955, Dr. Jonas Salk developed the first oral polio vaccine, and it arrived to the Mayo Clinic one day after its licensure. In 1961, Dr. Albert Sabine developed the second polio vaccine, and a third would be released in 1963. By 1994, polio was considered eliminated from North and South America. Pictured here is the very first shipment of the polio vaccine. We can draw a lot of lessons and parallels from the polio outbreak from 1949 to 1952. Many of the precautionary measures and recommendations given to people to protect themselves from polio are fairly similar to what we experienced during COVID. Also, similarly, there was widespread testing and reporting of cases because of the massive impact it was having on society at the time. Polio and COVID both challenged the healthcare systems with the large influx of patients needing treatment, oftentimes critical care, and not enough resources or staff to accommodate. But if there's one singular lesson we can draw from the polio epidemic, it's that vaccination saves lives, and as a society, we can protect each other when we utilize vaccination as recommended. And then these were the references that I used for my presentation.